Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, and comments that you wish to share with the audience can be typed into the chat box, visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweet or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other peoples have made in shaping and strengthening this community, our province, and the country. Today, we're delighted to bring you Pathways in Autism Spectrum Disorder, Part 3, Mental Health, Risk, and Resilience. This is the third and final webinar of this three-part series. And I'd like to introduce our speaker for today. Dr. Terry Bennett is a child and adolescent psychiatrist, a member of the Alfred Centre for Child Studies, and an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Dr. Bennett's clinical and research interests include children and families with autism spectrum disorder and neurodevelopmental disabilities, as well as pathways in child social development and mental health, how children's social brains and social worlds influence and are influenced by their mental health. Just a reminder that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. And I'll pose your questions to Terry following the presentation. It's now my pleasure to pass the mic to Terry.
Thank you so much, Paula, for that introduction. I'd like to say that I'm also presenting on behalf of Connie Kearns, who developed this presentation with me and unfortunately couldn't be here today, but I will present her slides on her behalf. I want to, as Paula's mentioned, this is the third in our webinar series, and I'm going to try to build on what you may have heard if you had attended the past sessions. And in particular today, as Paula mentioned, we're going to focus on mental health. Today in particular, we're going to take a longitudinal approach. So thinking forward in pathways to look at ideas of risk and resilience in terms of specifically looking at early mental health signs and signals. We want to then take a look. I will present Dr. Kearns' work looking at emotional problems and suicidality in children on the spectrum in our study. And we're going to focus throughout on how we can apply these findings when we think about these things as families, as parents, and as clinicians and service providers. So just a reminder that the Pathways in ASD study is a multi-site study that's been taking place for several years now across Canada. We have 5 sites from the west to the east coast in BC, Alberta, Ontario, Quebec, and Nova Scotia. The aim really is to look at how kids who were diagnosed at an early age, between the ages of 2 and 5, have been growing and changing between the time of their diagnosis with an autism spectrum disorder to now the end of adolescence. This study takes what we call an ecological approach. That is, we're thinking always about kids and youth within the context of their family lives, the services they may or may not receive, their schools and their communities. While some of the studies I'm going to discuss will have slightly different numbers of participants depending on the time points and the ages of the kids that are involved at that point, in general, I want to give you an overview of and a reminder really of the pathways sample of participants. So these are the kids and families who participated. So as you can see here, Montreal is the largest site. And at the time of our study enrollment, there were 134 in Montreal, and other sites ranged from 56 up to 93 participants. There's a range. We engaged and enrolled a range of kids in terms of their cognitive ability profiles, from those who have comorbid intellectual disability to those who have a more normative cognitive profile, and similarly a broad spectrum of language ability. The average age of enrollment was around 3 years old, and we aimed to enroll, this is what we call an inception cohort study. So kids were enrolled within 4 months of their diagnosis. And this was really aimed at achieving a representative sample of children at the time of their diagnosis moving forward. As is very common in studies of kids and youth on the spectrum, we have a preponderance of boys at around 84-85%, with about 15 to 16% of our sample at time of enrollment being girls. When we think about mental health studies, we can think in really two ways. The first way is a cross-sectional study. These types of studies are important snapshots, and at the level of particularly when they try to achieve a representative snapshot of a population, cross-sectional studies at one point in time really help us understand broad patterns of strengths and challenges in a certain population of kids or adults, and really also ideas like the burden of illness, how common things are, or severe problems, how common things are, and what other kind of features are they associated with. Longitudinal cohort studies, on the other hand, are really often focused on describing developmental processes and change, and they can be quite useful, and that's how we're really thinking about our pathway study. They're useful in generating ideas about how predictors and outcomes might be linked over time. When we have this kind of information, it can be very helpful then to think about, well, okay, then what kinds of attributes or what kinds of contexts are modifiable? So they're important springboards for then thinking in a next step type of research study in terms of intervention. For example, cross-sectional studies have shown us more recently that about 70% in some major cross-sectional studies of children and youth on the spectrum, that upwards of 70% of kids are experiencing significant degrees of mental health problems when they already have a diagnosis of an autism spectrum disorder. And so when we think about longitudinal cohort studies such as this one, this then kind of makes us think, okay, for a study like Pathways, can we think about what are some early signs or red flags for later mental health problems? What are risk factors? What are certain characteristics of kids or families or their contexts that might increase the chances of having more negative or challenging outcomes down the road? What are protective factors? What are the factors that when these are present in kids and families, the chances of having stronger mental health outcomes may be higher? And can we really identify profiles of risk and resilience? Are there patterns that make a lot of sense in terms of helping families and clinicians and service providers really understand how to identify and better support kids and families? I'm going to describe 3 studies. This first study that I'm going to describe is by Dr. Tracy Vaillancourt and the rest of our team. So Dr. Vaillancourt is the lead investigator on this study at the University of Ottawa. Dr. Vaillancourt was interested in really looking at early onset, internalizing problems and externalizing problems. So when I say internalizing problems, I'm going to refer to these are challenges that kids and adults experience related to things like anxiety, sadness, withdrawal. And whereas externalizing problems are often related to difficulties with inhibiting certain behaviors, hyperactivity, conduct problems, difficulty following the rules. So I'm going to refer to internalizing and externalizing problems a bit throughout this talk. We know that in neurotypically developing kids, that when in these kinds of challenges in mental health start early, they're often signals of more severe impairment over time. They have a higher likelihood of being chronic. And they're about equal in the early years between boys and girls, whereas in the adolescent years, that gender balance can switch towards a greater vulnerability for female youth or girls. So Dr. Vaillancourt is interested in thinking about, well, what do we know about young children recently diagnosed with ASD? Do they demonstrate similar early pathways in preschool mental health? So in this study, 392 children were included, and who were diagnosed as preschoolers within our autism cohort study. They were recruited through academic centers, as is the approach with pathways. So these are academic and regional autism diagnostic centers. Parents reported on their kids' feelings and behavior across 4 time points, from the time of diagnosis to the time of school entry. And using a latent class growth analysis, Dr. Vaillancourt and her team looked at examining group-based trajectories. So can we see group profiles of kids in terms of how their mental health symptoms unfold from the time of diagnosis of autism to around age 6, around the time of school entry across many provinces? Based on what we have seen in the research on kids with neurotypically developing profiles, we hypothesized that autism symptom severity, more cognitive challenges, lower family income, and being a boy at birth, so sex at birth of male, would be associated with greater, more severe difficulties. And here's what Dr. Vaillancourt saw. First, looking at that internalizing, those sadness and anxiety group profiles. What she found was that about 77% of children followed a trajectory from time of diagnosis between the ages of 2 and 4 to time of school entry that was lower and decreasing. So they had a more kind of protective trajectory with respect to internalizing problems. However, it was clear that from about 23% of the sample, so about 1 in 4 followed a high internalizing trajectory that was high and stable. So those kids who had a lot of difficulties with fearfulness, anxiety, and inhibition at time of diagnosis tended to continue to have high difficulties at the time of transition to school. When we look at these externalizing or conduct and hyperactivity problems, really 3 profiles of longitudinal profiles emerged. First, we see that in about 40%, they had relatively low levels of difficulties with acting out problems. And these problems decreased even further by time of school entry. Another group saw what was a moderate and declining trajectory over time. Whereas in this case, about 14% of kids, so those who were diagnosed in their preschool toddler years who had the highest levels of difficulty with challenging behaviors, tended to continue to have higher levels of difficulty. So they were quite stable again at school entry. And we saw that for about 13% of this group of Pathways participants, these kids who had challenges in both internalizing and externalizing problems, so a mixed profile. What was important was that while there were no particular associations found with child IQ and autistic symptoms, more girls than boys were found in the high internalizing group. So female sex assigned at birth seemed to be a risk factor for earlier high internalizing trajectories. And of note, lower household income was linked to more severe trajectories in both types of problems. So the bottom line for that is that in about 1 in 4 clinically of our participants had clinically significant emotional or behavior problems. Among the others, preschool years were shown, as we see in neurotypically developing populations, can be a time of stability or gains in self-regulation. But it's what the take home is that really when kids are presenting for their time of diagnosis for their autism assessment, it is really important to look for childhood emotional and behavioral dysregulation as red flags. And while I don't have time to discuss these other studies in length, I want to point to some other studies by Danielle Baribeau, Rakib Tesfaye, and Anat Zeidman-Zayat, who've also looked at early associations between repetitive behaviors and later anxiety problems, and then early sleep difficulties as a marker for emotional dysregulation. So when we think about applying these findings, the bottom line from this study is that when services are assessing kids for the first time for an autism diagnosis, it is also important in the context of also assessing their cognitive, language, and adaptive functioning, not to forget an assessment for child mental health, because very early on, severe difficulties in these domains appear to be a marker for chronic and persistent difficulties through the preschool years. And I'll say stay tuned as our teams are continuing to look at longer-term trajectories of emotional dysregulation and mental health problems over time. Now, recall that from webinars number 1 and number 2, we had a few major take-home messages, and among them were that first, it's really important in the midst of talking about risk to also talk about strengths. And so it's always important to ask about the best things about kids and families, and the last seminar really focused on that. We also discussed in the previous seminars how caregiver or parent stress and distress is really multifactorial. So while child behavior may be linked in both bidirectional, so back and forth ways, and also leading from parental stress and mental health challenges to greater challenges with child behavior, it's really important also to consider several contextual factors that I'm going to speak about a bit more. And finally, we know from the study presented as well last time was that early family functioning is an important protective factor when we think about later emotional and behavioral well-being in middle childhood. So in the context of thinking about this, can we also then move to thinking, okay, practically speaking, can we identify family profiles of strength, risk, and resilience? Since we know that family functioning, caregiver stress, and caregiver well-being are very important. Practically speaking, how can we support families earlier? So Dr. Anat Zeidman-Zayat built on her earlier repertoire of studies by asking this question: what are the profiles or patterns of family personal and social coping resources at the time of kids' school entry? So again, in Canada, it varies a bit, but approximately from kindergarten to grade 1. And looking at these profiles, are any of these profiles associated with important child and family outcomes 2 years later, so getting into the elementary school years? How are these profiles related to caregiver stress and depression, and kids' academic achievement, adaptive behavior, and behavioral problems? So looking at these profiles using a latent profile analysis, what Dr. Zeidman-Zayat looked at was taking this line represents an average across some key variables that we're going to look at in terms of family profiles of social coping. So looking at the first profile, I'm going to draw your attention to, first of all, we looked at socioeconomic risk. So things like household income, family contextual stressors and life events, as well as parents' educational achievement. Dr. Zeidman-Zayat then looked at as well, including caregiver coping styles, which were seen earlier as important risk and protective factors. Engaged problem-focused coping means that when you're faced with a problem, what is your pattern? What is a person's pattern in terms of addressing the problem through proactive brainstorming, discussion of different pros and cons, and really engaging with the problem. Disengaged coping refers to avoidance of situations that are associated with negative feelings. Family functioning looked at how well a family's managing in terms of discipline, positive supports, relationship quality. Social supports examined, for example, friendships and the extent to which people feel supported informally in their networks. And professionals' family-centered support looked at the extent to which caregivers perceived their autism service involvement as being family-centered. Looking at this first profile, so 4 profiles were found. Looking at this first profile, the team found that that in about 39% of families followed a profile of relative strength, such that caregivers reported that in their personal repertoire, they tended to engage in higher than average levels of problem-focused coping. And in particular, they had about average levels of family functioning and social support. So this is about 39%. And this is important because 2 years later, following this particular profile was associated with lower levels of caregiver depression 2 years later. In looking at this second profile, this profile in green, in this particular profile, you see a pattern where caregivers are reporting that for them, they have challenges with coping, with problem-solving coping, and also that they tended to have reduced social resources. So they were referring to having fewer social supports, less evidence of feeling family-centered involvement in their child's program of care, and poorer than average family function, within the context of about average socioeconomic risk. What was seen here was that these parents in this particular group, and most of these parents were mothers, all of these parents were mothers in this particular study. They reported higher levels of caregiver depression and parenting stress. However, of note, kids of parents in this profile demonstrated 2 years later about average levels of child behavioral problems versus well-being, and about average levels of adaptive functioning and academic outcomes. So in many ways, we can see this as a resilience profile of sorts. While it's very important, caregivers were reporting reduced coping and stress, and kids were functioning pretty well. So this is what we might kind of think about as a resilience pattern. And I'll come back to that in a bit. Looking at profile number 3 here in the purple. So this particular profile is characterized by parents who are describing about average levels of coping. And what's notable here is that they're demonstrating elevated levels of social resources. So these parents are reporting that they have high levels of family functioning and well-being, and that they're really accessing social supports, both informal social supports and high levels of family engaged care at the time of school entry. This was associated 2 years later with improved parent well-being, reduced parenting stress, and higher levels of child functioning and well-being. And finally, looking at this red profile here. In this particular profile, what we can see here is that parents were reporting high levels of socioeconomic challenges. So they were struggling, that they were facing kind of higher burdens socioeconomically. They also reported the highest levels of disengaged coping, so tending to have a more avoidant coping style when problems arise. They also described, quite strikingly, the lowest level of social resources. So significantly lower social supports and more challenged family functioning, and lowest levels of family-centered support. And what we saw was that 2 years later, these parents reported high levels of depression and parenting stress, as well as greater challenges with child behavior, child academic functioning, and child adaptive functioning in comparison to the other profiles. So this is really what we're seeing as a risk profile for parents. When we think about applying these findings, what what the team discovered was that really the most strongly predictive factors that were associated with later child and family outcomes were social supports and family functioning, followed by caregiver coping. And that socioeconomic status and family-centered care did vary across the profiles in a somewhat different way. If we look at the numbers, about 67% of these families, we could think of them as really being families who at that particular point in time were reporting that they were doing well with respect to social coping and to social resources rather, and family coping. Whereas 20%, that 20% group you could see as being in the middle, that was a group that you would want to pay attention to. And finally, 13% in that fourth profile parents were describing really crisis levels of difficulties in many ways. And when we think about this, I really appreciate this study as a clinician because it helps us to think about tiered levels of family-centered care so that when we think about families, can we assess social supports and family functioning and caregiver coping? And when all of these things appear to be strengths, offering recommendations or services that continue to strengthen or embellish kids' lives is really important. When there's concerns noted in these areas, it's important to get a sense of whether or not this is something that we can think about as targeted prevention. Can we think about these families where maybe their children are doing okay at the time in terms of mental health, which is my job as a psychiatrist to look after, but we see some red flags, and so we're thinking down the road. Whereas in 13%, we want to think about really a suite of resources that can support families more intensively when these supports are needed. So again, building on what I had said after the last study, in addition to assessing child mental health at any point in time, if you're a clinician seeing kids, can we also think about assessing caregiver and family well-being and resources in a way that's supportive, non-stigmatizing, and really action-oriented and linked to services? I'm going to turn now to Connie Kearns' slides with gratitude to her for having developed them. And I'm going to talk about a study that Connor and Michelle Hunsky developed that looked at suicidality in kids in the Pathways cohort. So what we know is that adolescents and adults on the autism spectrum have enhanced rates of suicidal ideation compared to neurotypically developing kids and adults. So identifying suicidality earlier in development, again, thinking ahead, is really important to help identify and support at-risk youth. And studies to date are growing in this area. However, they tend to be limited to those cross-sectional snapshots. They tend to include broad age ranges in the samples of kids, and they tend to be samples of kids who are already presenting for clinical services. So kind of biased samples. In this particular study, the team aimed to look at suicidality and its persistence over 4 time points in school-aged children on the autism spectrum. So these were kids a little bit further along down in their age trajectories. They identified kids at enhanced risk. The aim was to identify children at enhanced risk for suicidality. And in particular, they looked at these variables. So sex assigned at birth, adaptive functioning, and internalizing symptoms. So again, that's sadness, anxiety, and externalizing symptoms. So again, the acting out or behavioral dysregulation. In the first, they looked at 2 samples based on available data. In the first sample, 99 children had complete data at T1 at the first time point, which was at age 7.5. With complete data across all time points. And so this is age 7.5, 8, 9.5, and 10.5 years. In the second sample, had a larger sample because they looked at kids with data at least 1 time point and about the same ages. Using the child behavior checklist, they asked, the team looked at parent reports based on this item on the CBCL, which is my child talks about killing him or herself. And then parents also reported on their kids' adaptive ability, their internalizing and their externalizing symptoms. And here's what they found. In terms of the rates and persistence of parent-reported suicidal thinking, 12% of the sample of parents reported that their child had talked about killing themselves at any one point, at more than one time point, one or more time points. And of these, about 1/3, so at 2 or more time points, about 4% of this sample, so about 4 children, did parents describe that their kids had talked about killing themselves. Looking at whether there's any understanding of characteristics of kids who may be particularly at risk, looking at that second larger sample, they're interested in what child characteristics were associated with their parents describing them as endorsing suicidal thoughts or intentions at any time point. And they found that adaptive functioning level was significantly associated with suicidality. So kids who had higher levels of adaptive functioning, so that's higher levels of social and communication functioning and daily living skills functioning, these kids were more likely to report suicidal thinking compared to those with lower levels of adaptive functioning. However, when you look at this, because of the nature of the reported symptom, it's quite possible that this could be due to youth communication abilities and also the use of parent report. So parents had to be able to say that my child has voiced this concern. Sex assigned at birth and internalizing and externalizing symptoms, however, were not actually associated with enhanced risk of suicidality in the school-age community samples. But overall, recalling that but 12%, it's not only at all, but 12% reported at any time point, the low rates of suicidality overall can make identifying factors a little bit tricky in this sample size. So what do we take away from this? Well, 12% was high. Suicidal thinking in children at a rate of 12% is more common than in a same age general population sample in which reports around 1 to 2%. It is lower than at the lower end of some clinical samples, and keeping in mind that this is a community-based kind of sample in the pathway sample. These are not kids who are only presenting to mental health clinics. Furthermore, that in 1/3 of the sample, so 4 children, this was a persistent issue. And given what we found in this study, it seems that we may be better able to detect suicidal talk in children with higher functional abilities. And of note, though, internalizing and externalizing concerns weren't clear indicators at this age. And we will continue to follow kids through adolescence, so stay tuned for that. So in terms of what we don't know still, and what as a result of this study, we don't know in research, there isn't a sense of the extent to which parents' reports may underestimate suicidal thinking. This was a parent report and not kids. More research needs to be done into whether suicidal talk in kids on the spectrum evolves into attempts, and if so, at the same rates and the same patterns as neurotypically developing kids. And we also need to understand more what factors explain this increased risk in suicidal thinking so early on. So more work needs to be done. I'm going to turn now to thinking clinically about pulling together what we've talked about in this presentation. So when we think about that idea of longitudinal cohort studies and thinking about how can we translate these findings into next step studies, or even thinking about tailoring our clinical services to better support the ecology, kids within their contexts of children on the spectrum. One, I want to bringing you back to the research that I've described so far. One of the things that we want to think about is, can we move from this idea of pathways in ASD research to pathways in care? thinking back to last week's seminar, where really the team talked about the importance of bolstering best things, the importance of keeping in mind that every child and every family has their profile of strengths. It's important to think about that with any child that walks through our door. Can we think about how can we bolster best things in these families? When things are going well for children and families, for example, at the time of diagnosis, if families are reporting a lot of supports, a lot of coping, can we support them to look ahead and to prepare for the next transitional period? And can we think about check-ins not only for children at various points along their service pathway, but can we also think about regular check-ins for their families? When can we keep our eyes open for early signs of red flags? So, for example, again, at the time of child's diagnosis, at the time of transition to school-aged years, at the time of thinking about adolescence, can we, in addition to assessing autistic symptoms and functioning, can we keep an eye out for early signs of fearfulness, anxiety, and withdrawal, of hyperactivity and irritability that even when it's manageable at a certain age, can we again do that thinking ahead and think about targeted prevention? Can we ask about caregiver and family strengths and also family strain? And when we see it, can we see this as a red flag as well? And can we be prepared as clinicians to have resources in place, ideally in-house, as we mentioned before in this webinar, but and if not in-house, can we support families in their service navigation more carefully with due diligence? Can we also, although I didn't speak directly to the idea of kids' social lives, peer problems and bullying are common red flags in mental health. And can we keep an eye out for this as well? When we see these child, family, context level red flags, can we think about intervening more intensively to prevent problems down the road? And finally, when we think about clinical intervention, do we have evidence-based services in-house for mental health in kids with autism spectrum or autistic kids and youth? And this includes challenges such as clinical anxiety, depression, and suicidality, and severe dysregulation. Can kids have access to mental health services, both within their autism program and access as kids, youth, and adults to appropriate mental health services more broadly? One approach that we're trying to work on at McMaster Children's Hospital, where I work, is this idea of being able to move from what we know about ecological studies of kids within families over time to models of ecological care. And in our family checkup program, where we've, in mental health, we have imported an evidence-based family-centered intervention. We're now looking to adapt this intervention for families of kids on the spectrum and for children and youth on the spectrum. And really, this is that idea of thinking back to the research that I shared with you from the family profiles work. Can we integrate family assessment and intervention in-house within autism services so that families can feel supported to address all of the needs that we know affect not only child well-being, but family well-being over time? Some key components that have been outlined in ecological models of care include, as we discussed, being strength-based. So starting conversations with what are parents' strengths and what are kids' strengths, and how can we leverage these in their models of care? Can it be assessment-driven? Not only autism symptom assessment and functional assessments, but can we actually, as I outlined earlier, assess profiles of family strength and challenges and caregiver well-being in a way that's supportive? Linked to these assessments, we need tailored care. So, for example, if a parent is describing challenges in their well-being, can we provide supports to link them to mental health services? If they're describing that things are going quite well in terms of their family functioning, but they're struggling, for example, with socioeconomic resources, is that capacity there to connect them with appropriate supports in the community? Family-centered care is also motivational, and that really means having collaborative discussions with caregivers and thinking about where they're at, caregivers and youth, in terms of their strengths, what their perceived goals are, and what are some of the facilitators in meeting these goals, and what are things that are getting in the way. And this means that we need to incorporate therapeutic approaches such as empathic reflection, motivational interviewing, and some more emotion-focused approaches to support children and families within the context of evidence-based services. So, for example, in our family checkup clinics, we have discussions with caregivers and with children and youth that ask and really listen to questions such as, how is my mental health? How do we communicate in our family? How do we tackle our problems? How do I co-parent with my partner, my spouse, or my child's other parent when that's the case? Where are the stress points in my life, both related to parenting my child on the spectrum, but really also to the vagaries of life in general? Who are my supports, and am I accessing them? What are my strengths? What are my strengths as a kid, as a teenager? What are my strengths as a parent? And where are some areas that I want to work on? And parents can think about, what are my child's strengths? How do I want to grow them? And how do we have fun together, building on their strengths and interests? And finally, are we showing ourselves compassion within family? And if so, who can we reach out to for supports around this? In having these kinds of assessments of all known risk and protective factors for child and behavioral, for family and child well-being, having these collaborative discussions, you can then come up with a menu of services that's really very tailored. And this is just repeating some of the points that were discussed earlier in these webinars. And there are a range of, there's an increasing wealth of evidence-based research, I would say, in the past 5 years that is really looking at improved support for families, caregivers, and kids. And these are just some of the lists. For example, mindfulness-based stress reduction, acceptance and commitment groups for caregiver or parent mental health, family management supports, which is also known as parent training, but really supporting caregivers in a tailored way to think about where are their strengths as parents and what are some parenting strategies that they may want to implement to support their kids' behavioral self-regulation and well-being, problem-solving therapy, couples therapy when necessary, and family transition and support when families are, for example, going through change as a result of grieving the loss of a grandparent or going through divorce or separation. I'm going to speak briefly to Connor's work looking at cognitive behavior therapy, but also for kids we think about social skills development, which may have some secondary outcomes on mood, and as well as medication approaches. And these include approaches to medication for ADHD, as well as irritability and hyperactivity. And I'm happy to answer questions about that afterwards. In particular, I want to just briefly finish by touching on cognitive behavior therapy. So we know that CBT is an effective treatment for anxiety in neurotypically developing kids with anxiety, as well as verbally able autistic children. In this study that was published last year in JAMA Psychiatry, Dr. Connie Kearns and her colleagues looked at cognitive and adapted CBT approach that was adapted for children and youth on the spectrum. And they compared it to Coping Cat, which was a CBT approach for neurotypically developing kids with anxiety, and compared to treatment as usual. Across all studies in general for CBT, we know that 58 to 71% of youth experience remission of primary anxiety disorder. So these are quite effective intervention. What they found, as you can see by these lines, is that in this adapted behavioral intervention to support behavioral intervention for autistic children with anxiety, or BIACA, they found that kids who participated in the tailored approach demonstrated improvements over CBT as usual, and both groups showed improvements over treatment as usual for anxiety in kids with ASD. And in fact, improvements were demonstrated not only in anxiety, but also in autistic behaviors, and daily living skills. And this slide really speaks to the importance of ongoing work for CBT, particularly for those with lower language ability and a broader range of intellectual abilities. For our final bottom lines, I would just want to reiterate that it's important to identify and build on family strengths. We want to be able to identify child mental health problems and intervene early. And again, independent of autistic symptom severity, it's important to assess child mental health problems. We want to identify profiles of risk and protective factors at the level of the family and intervene even earlier before, as much as possible, before mental health problems emerge. And to bake in ecological models of care that are tailored to child and family needs, tiered to incorporate prevention as well as intervention, that are flexible and supportive of families, and that are evidence-based. It's important to continue to think about research and prevention, to think now about intervention, and can we act on some of these to change some of these variables that have been predictors of strengths and challenging outcomes. And in particular, there's more research that is coming, but more research that is needed for depression and suicidality in kids and youth with autism. Stay tuned for our next, we're working currently on analyzing surveys of families from that we obtained during COVID. And we're also looking at next steps to study how families and children on the spectrum are doing as they transition to adulthood. And I'd like to thank all of my wonderful colleagues and the staff, and a special thank you to the many children, youth, and families who've participated in the Pathway Study, from whom we've learned so much, really, in the last 2 decades. And with that, I'm happy to take any questions you might have. Thank you.
Thank you, Terry. There are a couple of questions here.
Okay.
The first from Elise. She said, just curious, regarding the suicidality research, was the comparison to neurotypically developing children's suicidal thoughts from the literature at roughly 2%, also from parent reports?
You know what? That is an excellent point. So the comparison, in that study, they didn't do a direct comparison. So those are general comparisons to research that's out there in the literature. So they didn't do direct. We just looked at reports of suicidality within the Pathways cohort. And that's in general compared to reports from the child neurotypically developing literature. So I'm not sure, actually. That's an excellent point.
Another question with regard to you collected data around socioeconomic status. Was ethnicity or race also looked at as a factor? Perhaps cultural practices in parenting, or lots of other potential issues or concerns?
Oh, that's such an excellent question. We didn't look specifically at ethnicity. I'm trying to remember if in that risk profile, whether recent immigration or recent arrival was included, but I think it wasn't. I would have to go back and look at that, but it wasn't looked at specifically as what we call like an independent variable. And we haven't looked at that specifically. That's a very interesting question. We don't have a lot of nuanced data or reports about parenting practice, but I do think that is such an important question to look at in terms of strengths. Certainly, we have in terms of social supports as well, that can differ across communities. And so that's an important kind of piece to consider. But looking specifically at different cultural views of parenting and really parenting practice in general is an important next step.
Great. You talked about targeted prevention. Is there any guidance to families prior to the identification of their child as being on the spectrum as to what to watch out for? Is there much out in the public domain for parents in general?
I think in general, when we look at the child mental health literature and prevention and well-being, that in some ways, in terms of looking at risk and protective factors, they're really transdiagnostic. So I would say, looking if you're having concerns with early irritability, with really a lot of difficulties, for example, with kids who are quite either quite shy and anxious, or irritability, anger, aggression, and acting out, one of the interesting findings is that looking at, as a parent, how you can support your kids, the family management supports or parent training. So these are programs like Triple P, parent-child interaction therapy. The effect sizes for this type of approach, and many of these programs are available in the community, tends to be quite similar in systematic reviews of families with kids on the spectrum, as in families of kids who are not autistic, but at risk of anxiety or other outcomes. So that's the one thing, that many of these programs are really helpful, regardless of whether your child has a diagnosis on the spectrum. And the CBT work, that JAMA psychiatry study, one of the takeaways from that is that while adapted CBT, which was adapted in terms of the specific focus of the sessions, more supports around particular autistic symptoms and more caregiver involvement, while the adapted CBT for kids on the spectrum demonstrated some improvement, certainly CBT, or cognitive behavior therapy, demonstrated benefits above and beyond treatment as usual. So I think, again, I know in my community in Hamilton, there are some freely available child groups that look at CBT for anxiety, and those, again, can be really helpful. But looking for really early difficulties in kids' ability to control their emotional reactions, both in terms of how really strong their emotional reactions are, or if it's something that you feel like you're struggling with on a day-to-day basis. Talking to your family doctor or talking to your local, to any local family support agency can be really helpful.
Great. And you spoke of next steps relating to COVID and its impact on kids. How did COVID impact your studies themselves?
Oh, that's a great question. So, I mean, as so many, it has been a challenge in that what we wanted to do was to make sure that we had some sense of continuing connection with families while not overburdening them with participating in kind of research, in a heavy research battery, and we couldn't continue to see families and kids in person. So instead, what we did was we asked families to complete a couple of COVID questionnaires, so that really in the aims of understanding how they were coping during COVID, how their kids were doing, how they were doing as a family. And so this is data that we're just starting to collect, that we're hoping to analyze and really share soon in the next several months.
Oh, great.
So we had to kind of pause it and then really focus on that.
Mm-hmm. Yeah, we all pivoted at some point, didn't we?
I was trying to avoid the use of the word pivot.
Yep. Oh, I'm sorry.
No, I know. I'm just laughing because it's after you're on mute. It's the most common thing.
Yeah, really. It's ubiquitous now. Well, that's the end of our questions. So, Terry, I want to thank you and Dr. Kearns, who unfortunately couldn't make it, for sharing your time and expertise with us through this presentation. I want to thank all our members and other attendees for choosing to join us. We know how busy you all are right now, and we hope you depart with some practical knowledge to bring back to your organization. You can join us on June 23rd at 12 Eastern, when we're pleased to bring you Exploring Structural Inequities in Early Child Development and Intervention with Indigenous Families and Children, and Advancing Trauma and Violence-Informed Care. We invite you to save the date for our 2021 annual conference, taking place virtually this year from November 22nd to 26th. And the theme is From Crisis to Catalyst, the next chapter for children's healthcare. Just to note, the call for abstracts for posters and member spotlight sessions closes on June 13th. So get those abstracts in. It's always great if you can join us live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Terry and to Connor and the rest of the Pathways in Autism Spectrum Disorder study team for this presentation, and hopefully we'll see many of you back here on June 23rd. Bye-bye for now.